Hello my dear friends, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular session, I'll be just giving you a recent updates on COVID-19. So this particular data, whichever I am discussing, is the data which is updated on December 18th, 2020. So because of the pandemic still going on, this COVID-19, the data is changing every day. As of December 18, 2020, the confirmed cases all over the world, they are nearly around 7 crores 53 lakhs, whereas in India, it is around 99 lakhs 79,447. And if you take the deaths as well, the deaths in India, they are nearly around 1,44,000. And recovery rate, if you see all over the country, recovery rate, if you see globally, the India, it has the best recovery rate. Now, following that, as everyone is aware of this particular routes of transmission of the COVID-19, that is through the aerosol route and as well as by direct contact. But what is that I am discussing in this slide is that, see, the COVID-19 can be spread by contact, but what should be the diameter of that particular droplet? It should be more than 5 micrometers in diameter. And in case of direct contact, the spread can occur easily. That is, what are the portal of entry for the direct contact for the aerosol to enter into the individual is through eyes, nose or mouth. Whereas the spread can occur through aerosols also. So the spread which is occurring through the aerosols, the diameter is less than 5 micrometers in diameter. So through contact, the droplet size should be more than 5 micrometer in diameter, whereas through aerosols, it is less than 5 micrometer in diameter. Okay, so these are the new points what you are learning in this slide. And the other important point is the RNA of this particular COVID-19 is also found in the urine and as well as the feces. Right? It is also found in the urine and as well as feces. Now, subsequently, let me tell you the immune response to COVID-19. So if you take the immune response to COVID-19, the point that you should understand here is the virus enters into the individual. Now it all depends upon, the immune response completely depends upon whether it is a low viral titer which has entered or if it is high viral titer which has entered. For suppose, if it is a low virus titer which has entered, then the individual will have a mild immune response. If the high virus titer, if it has entered, then the individual will have a very severe immune response. Now, that particular immune response will be in the form of the cytokine storm. So what actually happens is, this particular high virus titer will go and activate the policemen of our body, that is, the monocytes and as well as the macrophages. So the monocytes and as well as macrophages, they will try to kill the virus by releasing the cytokines. Right? Whenever there is a high virus titer, there will be a very significant cytokine storm. And these particular cytokines which are being released include interleukin 6, then interleukin 10, then the tumor necrosis factor, that is TNF. So these are the cytokines which are released into the circulation. Now these particular cytokines which are released into the circulation by the activation of these monocytes macrophages, they are the one which are responsible for the organ injury, the tissue injury. Okay, so these particular cytokines, what they will do is they can cause lung injury, right? And they can also cause the septic shock, the organ failure and as well as the coagulopathy. So before the development of the lung injury, before the development of the septic shock, before the development of coagulopathy, if you give the antivirals and anti-cytokine storm treatment, then the death can be prevented. Right? The death can be prevented. This is a very, very important point that you need to remember. Okay? So, what are the cytokines which are released into the circulation? Interleukin 6, interleukin 10, and as well as the TNF, tumor necrosis factor. Now, then followed by that, if the individual is having an adequate immune response, then in such case, you will have a very quick type 1 interferon response. Whenever there is type 1 interferon response, that will have an efficient antiviral activity and that can kill this particular virus. For suppose, if there is inadequate immune response, by the time the interferons are released, there will be significant endothelial cell death and that can make the individual to have a release of the cytokine storm. Right? That can make the individual to have a release of the cytokine storm. So that is the reason why the activity of the virus in the body completely depends upon the immune status of the individual. So every one of us know if the immunity of the individual is good, the chance of COVID-19 hitting him is less likely. And the point is, in case of elderly individuals, the COVID-19 will hit very badly because immunity is very less. Right? And why in case of children, the incidence of COVID-19 is less even though the immunity is less in them? Because for the entry of this particular COVID-19 into the cell, you require ACE2 receptors. And the number of ACE2 receptors in children, the cells of the children, they are less. And that is the reason why the COVID-19, it does not enter significantly into the cells of the children. Whereas an elderly individual, the immunity is less and ACE2 receptors are also high. And that is the reason why the entry is also good and immunity is also less. So that is the reason why in elderly individuals, they will have very poor outcome. The mortality rate is very high. Regarding the transmission, you need to know one of the very important point that if the individual is asymptomatic, can he transmit this particular COVID-19? This is very, very important point. So there was a study done multiple places and meta-analysis of all the various studies. What they have found was, even though the individual is not symptomatic, the chance of him transmitting the COVID-19 is nearly around 6 to 41%. Right? So in asymptomatic individuals also, the chance of transmission is there of nearly around 6 to 41%. Now, the other important multiple choice question that will be asked related to your COVID-19 is that, what are the agents which are required for inactivation of the virus? Right? What are the agents which are required for the inactivation of the virus? That includes 62 to 71% ethanol, right? 0.5% hydrogen peroxide, 0.1% sodium hypochlorite. These are the agents which are required for the inactivation of the virus. This will be the very, very important multiple choice question. And you take the benzalkonium chloride. So the agents which are not required, that means which cannot be used for inactivation, are benzalkonium chloride and as well as the chlorhexidine. So these are less effective in the inactivation of these particular viral agents. So this will be the very important multiple choice question. That is 62% to 71% ethanol, 0.5% hydrogen peroxide or 0.1% sodium hypochlorite. Okay. Now, the next important thing, I should appreciate one important country which has completely eliminated the COVID-19 is the New Zealand. So in New Zealand, the first COVID-19 case was found in February 26th. And by now, they have completely eliminated this particular COVID-19. Now, the other important thing is the prevention. See, healthcare personnel caring is very important. So, healthcare personnel, whoever are taking care of the patients suspected of COVID-19 or known case of COVID-19, what should be the preventive measures what they have to take? first and foremost, very important, they have to use the appropriate PPE kit, right? That is personal protection equipment. And they should be completely aware of the proper donning and as well as the doffing. Okay, so that includes gowns, gloves, and as well as eye protection. Now, those healthcare personnel who are taking care of the routine patient care, right, in the conventional settings, surgical mask or N95 mask will be enough. Whereas, if they are involved in an area where there is aerosol generating procedures, then in such case, they have to use definitely N95 masks. Whereas, if the healthcare personnel is in the area of crisis, then in such case, routine care is your surgical mask or N95 mask. But if the individual is in aerosol generating procedures, then he should have a complete protection. Gown, gloves, face mask, eye protection, everything is required. So, face shield or surgical mask covering N95 to allow extended use or reuse or reprocessed N95. So, these are the preventive measures that has to be taken by the healthcare individuals depending upon where they are working. Now, the other important concept that you need to know for your entrance exams is about the herd immunity definition. Right? Once the entire community develops the herd immunity, then there will be a complete protection to this particular COVID-19. Now, what do you understand by the word herd immunity? It is actually a protection. Immunity. Herd immunity, that means it's an indirect protection of the susceptible individuals. Who are susceptible individuals? Elderly patients or immune compromised individuals. So, indirect protection of the suspected individuals from infection when sufficient portion of population is immune. Right? When sufficient portion of the population is immune. So, this is very important, right? When sufficient portion of the population is immune, in the community, there is an indirect protection of the susceptible individual from infection. That is called herd immunity. I'll just show you the pictorial representation. Right, you see this. Now, he is a susceptible individual. Orange color is a susceptible individual. Now, in the community, if you have all the susceptible individuals only, the chance of transmission is very high. In other way around, the blue color ones, they are immune individuals, okay? Now, from a susceptible individual or COVID-19 infectious patient has entered into a community. But that community contain immune individuals. Only you have one individual who is susceptible. So, in this community, you see the chance of spread, right? So, immune, only he is susceptible, right? This person is susceptible. So, that means what is happening? If the community contain an immune individuals, the chance of transmission to the community is less likely. So, this is an indirect protection of susceptible individuals from infection when a sufficient portion of the population is immune. That is what is called as the herd immunity. Right? So, with this basic introduction, let me move on to the screening and as well as the diagnosis. So, first of all, you should know what exactly is the definition of a suspected case of COVID-19 according to WHO. Right? So, according to WHO, this is what is the suspected case. That is, when the individual has acute onset of fever and cough, that is 1. Or more than or equal to 3 of the following features. What are those more than or equal to 3 of the following features? Either the individual should have fever, cough, generalized weakness, fatigue, headache, myalgia, sore throat, coryza, dyspnea, anorexia, nausea, vomiting, diarrhea, altered mental status. So, more than or equal to 3 of the following if they are there, then it is a suspected case. Right? Then it is called suspected case. Alright? Or the other important thing is any one of the following within 14 days of the symptom onset. What is that one of the following within 14 days of the symptom onset? Like for example, if the individual is residing or working in an area with risk of transmission, right? A healthcare individual trying to give the services to the patients of COVID-19. That means the healthcare individual is residing or working in an area with high risk of transmission. So in them, if at least one of the following is there, then he is considered as a suspected case of the COVID-19, right? Or the individual is residing or traveling to an area with community transmission. In this scenario also, if any one of the above is there, you can consider it as suspected case of the COVID-19, right? Or working in a healthcare setting. Okay. So, if these three are not there, right? If these three are not there, then according to WHO, the suspected case is that when the individual is having more than or equal to 3 of the following features. But if any of these three are there, at least one of the following manifestation is there, then he is considered to be a suspected case definition, right? Suspected case definition. Now, TK. Now you have a suspicion. What is the next step? You have to do what is called as nucleic acid testing, right? So, I have a patient who is having high level of suspicion and I have a patient who is having low level of suspicion. And this high suspicious patient, he is not hospitalized, right? And I have collected the sample. It has come negative, right? I have collected the nasopharyngeal swab. It has come negative. What is the next thing? Do one more time. Repeat the testing. So according to WHO, minimum 2 samples should be negative in a highly suspicious case for COVID-19, right? Or if the individual is like hospitalized, okay, the individual is having low respiratory symptoms, and I have taken the nasopharyngeal swab sample, sent for the nucleic acid testing, and it has come negative. Repeat again, right? Repeat again. Okay. So in high suspicion for COVID-19, if one sample has come negative, repeat for the second sample. Minimum 2 samples should be negative to consider it as the individual is completely COVID-19 in a highly suspicious case. What do you mean by the word highly suspicious? Already I have said you just before now. Whereas in low suspicion of COVID-19, remember, even if one sample is negative, then do not repeat testing, right? Do not repeat testing. Okay, right. So one of the ways of confirming this particular COVID-19 is by your RT-PCR in a suspicious case. And the other ways by confirming the COVID-19 is by your chest CT scan abnormalities. So in case of COVID-19, remember, the pulmonary manifestations are in the form of interstitial pneumonia. So you will not have a classical changes, you will have atypical changes. And the hallmark feature on the chest CT images include the presence of bilateral, right? The presence of bilateral peripheral ground glass opacities, right? Bilateral peripheral ground glass opacities and consolidation of the lung, right? Consolidation of the lung. Okay, so these are the hallmark changes within the chest CT. But you have what is called as the 𝘄-RADS scoring, right? You have what is called 𝘄-RADS scoring. And this 𝘄-RADS scoring, like you have staging 1, 2, 3, 4, 5 and as well as 6. What is this? So in case of the 𝘄-RAD 1, right, the individual is not having any features suggestive of COVID-19 and the CT is normal or non-infectious abnormalities are there. Whereas in 𝘄-RAD 2, there is low level of suspicion and abnormalities consistent with infections other than COVID-19, because it is not just only COVID-19 which will cause interstitial pneumonia. There are many organisms, Mycoplasma, Legionella, Chlamydia, and you have viruses like cytomegalovirus, Epstein-Barr virus, right? PCP pneumonia. All these can cause interstitial pneumonia, right? So abnormalities consistent with infection but other than COVID-19. that is what is your 𝘄RAD 2. Whereas 𝘄RAD 3, intermediate level of suspicion. It is little unclear whether COVID-19 is present or not. That is what is your 𝘄RAD 3. And you take 𝘄RAD 4, right? 𝘄RAD 4. So 𝘄RAD 4, there is high level of suspicion, right? There is high level of suspicion. And abnormality is suspicion for COVID-19. And 𝘄RAD 5, it is very high and typical COVID-19 features, right? What are those? I'll just explain you in detail. Typical COVID-19 features. And 𝘄RAD 6 is PCR already positive. You don't require CT again for 𝘄RAD 6. Okay. So this is about the 𝘄RAD staging and associated level of suspicion in COVID-19. Now, what will be the COVID-19 changes, right? I said you that in case of 𝘄RAD 5, you have the typical COVID-19 changes. Now, what are those changes? So, if you take early stages, right? In early stage, that is around 0 to 4 days, the individual will have ground glass opacities, partial 𝘂𝐕𝐈𝐃, and lower number of the involved lobes. Whereas in progressive stage, right? In progressive stage, that is around 5 to 8 days, the individual will have extension of the ground glass opacities, and there will be increased 𝘂𝐕𝐈𝐃 pattern. And in the peak stage, that is around 10 to 13 days, the individual will enter into a peak stage where you have the presence of consolidation. And beyond 14 days, right, beyond equal to or more than 14 days, you will have the absorption stage where there will be a gradual resolution, right, where there will be a gradual resolution. So these are the CT changes over time. So early stage 0 to 4 days, progressive stage 5 to 8 days, peak stage 10 to 13 days, and absorption stage will be beyond 14 days. Okay, so these are the CT changes like what you will have in COVID-19. Let me tell you, RT-PCR, that is nucleic acid amplification testing, the ideal sample is the nasopharyngeal swab, right? Nasopharyngeal swab. Now, what has been found was the reports of negative pharyngeal and as well as sputum viral testing, but the fecal samples, right, the feces samples, they were turned to be positive, right? They were turned to be positive. So even the nucleic acid amplification testing can be done even within the stool, right? Even within the stool. Now the question is, nucleic acid amplification testing, yes, it is the investigation of choice and it's an ideal test. But before how many days of the symptom, right? Even though individual is asymptomatic, PCR is being done and the PCR is coming out to be positive, right? So how many days before the symptom onset the PCR can come positive, right? Let me show you pictorially. Okay, so this is the symptom onset, right? This is your symptom onset phase. Now the blue color line, right, which I have marked, this is the nasopharyngeal swab PCR. Even though the individual is asymptomatic, please remember the PCR can be positive up to 1 week before the symptom onset, right? So 1 week before the symptom onset also the PCR can be positive. Not even 1 week, even up to 10 days before the symptom onset the PCR can be positive. Okay, next. Now apart from the PCR, that is the nasopharyngeal swab PCR, the other what you can do is the viral isolation from respiratory tract, bronchoalveolar lavage or the sputum, right, and as well as the stool PCR. So these PCRs can be positive even before the symptom onset. But the ideal is your nasopharyngeal swab PCR. Now the antibodies, right? Now the antibodies. So if you take the antibodies, when do they appear? You take IgM antibody. IgM antibody is the one which is an acute, right? IgM antibody is acute. So IgM antibody when it will appear? So this particular IgM antibody, it will appear around the 10th day, right? So in between first and second week, you have the appearance of this particular IgM antibody in the individual. And this particular IgM antibody, this will stay within the blood up to 6 to 7 weeks. And later we have the IgG antibody. This can stay up to even 6 months as well. This IgG antibody, it tells that the individual had a past infection with the COVID-19. So that is about the temporal consideration for the diagnosis. So what you need to remember now? Even before the symptoms, the PCR can be positive. 10 days before the symptoms also, the PCR can be positive. That is, you need to do nasopharyngeal swab, right? Nasopharyngeal swab. Okay. Now, coming to the antibody testing, right? Coming to the antibody testing. Like we have many types of the antibody testing which is available in the market, right? What are those particular various antibody testing kits, right? What are those various antibody testing kits? They include the following. That is, you see, we have what is called rapid diagnostic testing. Rapid diagnostic testing, the word itself tells you rapid diagnostic testing. The result will be there in front of you within 10 to 30 minutes. Then we have ELISA, that is enzyme-linked immunosorbent assay. The report will be there in front of you within 2 to 5 hours. Then we have neutralization assay. Report comes within 3 to 5 days. And then chemiluminescent immunoassay. The report will be available to you within 1 to 2 hours. So what is that? These particular tests will detect antibodies. It will not detect the viral nucleic acid material. It will detect only the antibodies. Alright. Now, the point that you should understand here is which among the following is having the highest sensitivity. Which among the following is having highest sensitivity and highest specificity as well. So, you take this ELISA. The ELISA sensitivity is up to 100%. Even specificity is also up to 100%. Whereas you take rapid diagnostic testing, the sensitivity is only up to 99%. But whereas ELISA, the sensitivity can go even up to 100%. Okay. So these are your antibody tests. That is rapid diagnostic test, enzyme-linked immunosorbent assay, neutralization assay, and then chemiluminescent immunoassay. But out of all these, which is considered as the current test of choice? The current test of choice is the RT-PCR, where the sample has been taken from the nose, nasopharyngeal area. So the sampling, that picking up of the sample from the nasopharyngeal area should be little deep. Then only you can have a correct reporting. Otherwise, there can be false negative reporting, right? So this is about the investigations in case of the COVID-19. And if you take the natural history, clinical presentation and symptom spectrum in these individuals, first of all, you need to know the incubation period, right? The virus has entered into body. After how many days the individual can have the symptoms? Remember, there were many studies which have been done all over the world, and the meta-analysis of all the studies have shown that the median incubation period for COVID-19 is 5.1 days. This is an important multiple choice question. Right? The median incubation period is around 5.1 days. The next point is, the primary symptoms of COVID-19. So if you take the primary symptoms of COVID-19, remember this particular image every one of us know, that is congestion or running nose, headache, sore throat, cough, fatigue, muscle or the body aches, shortness of breath, nausea or vomiting or diarrhea. These are the primary symptoms of COVID-19. These are the primary symptoms of COVID-19, and these symptoms may appear 2 to 14 days after the exposure to virus. Right, 2 to 14 days after the exposure to virus. Now, among all these symptoms, which symptom is very common? Right, which symptoms are very common? And again, a study was done. Right, a study was done. And in that particular study, headache was found to be the most common symptom. And along with that, the other features like loss of smell, nasal obstruction, asthenia, cough, myalgia, rhinorrhea, taste dysfunction, sore throat, and as well as fever. Right? So, the most common symptom is what? That is headache. The most common symptom is the headache. Okay? Right. So, this is about the clinical presentation and the observation data analysis all over the country. Right? And as well as all over the world. Now, the point is that your COVID-19 is not just confined only to the lungs. COVID-19, it has cardiovascular manifestations, neurological manifestations, right? Cutaneous manifestations, right? Cerebrovascular manifestations. Okay, now why is this particular extra-pulmonary manifestations you have in case of COVID-19? Why? Because this particular COVID-19, the entry receptor is the ACE2. This is a multiple choice question. The entry receptor is ACE2. And this entry receptor ACE2, it is expressed across all the extrapulmonary tissues. Right? It is expressed across all the extrapulmonary tissues. So, through this particular ACE2 receptors, the COVID-19 can enter into the extrapulmonary tissues as well. Right? Can enter into the extrapulmonary tissues as well. Now, accordingly, what are those extrapulmonary manifestations? So, the extrapulmonary manifestations of COVID-19 is as follows. You have the dermatological manifestations, that is in the form of petechiae, livedo reticularis, erythematous rash, urticaria, vesicles, and pernio-like lesions. And there are also cardiac manifestations in the form of cardiomyopathy, that is Takotsubo cardiomyopathy, myocarditis. There can be cardiac arrhythmias, cardiogenic shock, myocardial ischemia, and acute 𝘄𝐕𝐈𝐃. So these are the cardiac manifestations you will have. Endocrine manifestations, they are in the form of hyperglycemia and as well as the diabetic ketoacidosis. Gastrointestinal manifestations, they are in the form of diarrhea, right? We have seen many patients presenting in the form of diarrhea, right? And thinking that it would be gastroenteritis, but later turned out to be COVID-19 infection. So, diarrhea, abdominal pain, and as well as the anorexia. And neurological manifestations, right? I have said you already, the headache is one of the very common manifestations, right? And recently, like we had one case of the Guillain-Barré syndrome, right? So, on the further workup, we have found the COVID-19, the RT-PCR was found to be positive. Okay, so the presentation can be even in the form of the Guillain-Barré syndrome as well. So, dizziness, encephalopathy, 𝘂𝐎𝐕𝐈𝐃, myalgia, anosmia, that is loss of sensation of smell, and as well as stroke. So, that will be the neurological manifestations. Hematological manifestations are very, very important, like the thromboembolic phenomenon. Hypercoagulability is very common in case of COVID-19. I will discuss in detail about the pathogenesis of like why there will be hypercoagulability. Right? And there can be deep vein thrombosis, pulmonary embolism, and the catheter related thrombosis. In the hepatic manifestations, right, hepatic manifestations will be in the form of elevated AST and as well as ALT, and there can be even elevated bilirubin as well. So these are the hepatic manifestations that you will have in patients with the COVID-19. And the next important thing is renal involvement. Renal involvement is in the form of the acute kidney injury, proteinuria, and as well as hematuria. So from this slide, what I want to tell you is the COVID-19 infected patients, they need not present only with the respiratory manifestations. They can present in heart failure. They can present in renal failure. They can present with transient ischemic attack. They can present with the Guillain-Barré syndrome. They can present with the cutaneous manifestations in the form of urticaria or vesicles which are being formed. Okay. So, any of these particular manifestations can be there in COVID-19. Okay. Now, TK. Now, the individual has been completely treated. What will be the post-COVID-19 follow-up manifestations? Okay. So this is the data from the Italy, right? This is the data from Italy. They have done a workup. During acute phase of COVID-19, what is the most common symptom? That is fatigue. And post COVID-19 follow-up, right? In recovered case of COVID-19, what is the post COVID-19 follow-up symptomatology which is more common, right? So that also they found to be fatigue as the most common symptom. Okay, so that means the post COVID-19 sequelae are present even after the individual has been completely being treated. Okay, right. Next, after this, let me tell you in detail about the co-infections and COVID-19. So if you take the co-infections and as well as the COVID-19, now why there will be co-infections? Let me tell you a proposed model. Right, let me tell you a proposed model for viral induced susceptibility to secondary bacterial pneumonia. Co-infections are very common. What are those co-infections? I will tell you. So first of all, virus has entered into the body, right? COVID-19 virus has entered into the body. Now in the pathogenesis also I have said you, right? There will be induction of the cytokine storm. There will be release of the interferons. And subsequently, there will be also release of the cytokines, that is interleukin 6, interleukin 10 and as well as interleukin 27. Now, this particular cytokines, what they can do is, they will cause increased mucosal responses and there will be loss of ciliary function and epithelial cell death. This word is important to me, that is loss of ciliary function, because the cilia which is present in the respiratory tract, that is very important for me to prevent the entry of the organisms, right? To prevent the entry of the organisms. Now, because of this particular cytokines, there is loss of ciliary function. So thereby, what will happen? There will be respiratory tract dysbiosis. What is dysbiosis? Imbalance, right? So now there will be entry of the organisms because there is increased mucosal responses and there is loss of ciliary function as well. Now, what are the organisms that can enter and can cause respiratory tract imbalance? That includes Streptococcus pneumonia, Staphylococcus aureus, Haemophilus influenza, Moraxella catarrhalis and Pseudomonas, and as well as the Acinetobacter. Right? So, these are the viruses, these are the organisms which can grow in COVID-19 causing secondary bacterial pneumonia. And not only that, in these patients with the COVID-19, because of the release of these interferons and as well as cytokines, there will be also alteration in the pulmonary immune response, right? Alterations in the pulmonary immune response, right? So there will be decreased macrophage and as well as neutrophil function, and there will be also decreased inflammatory cell recruitment, right? Inflammatory cell recruitment. And there will be also gut dysbiosis, right, where there is imbalance even within the gut as well. And the organisms are like Haemophilus influenza, Klebsiella, Lactobacillus. So these are the organisms. Okay. So this is like proposed mechanism why there will be secondary bacterial pneumonia. The concept is very simple. There will be excessive release of your interferons and cytokines, and they will cause the loss of ciliary function, and there will be increased mucus production, and that will disturb the respiratory tract balance. Right? That will disturb the gut dysbiosis. Okay, there will be gut dysbiosis, and accordingly there will be entry of the organisms causing secondary bacterial pneumonia. And if you take the data from one of the studies have shown that the chance of bacterial infections, that is secondary infections, that is co-infections, bacterial infections, they were found to be very common. And the other group of infections were fungal infections like Candida and as well as the Aspergillus. So this is about the data on the co-infections. And how do you assess the severity and as well as the risk factors for the severe disease? So the National Institute of Health, it has given a guidelines in defining the severity of COVID-19. Right, in defining the severity of COVID-19, and that includes the individual can be considered asymptomatic or pre-symptomatic if the test is positive but there are no symptoms. no symptoms, but test is positive. He is considered as asymptomatic or pre-symptomatic. Whereas the individual had varied symptoms like in the form of fever, cough, sore throat, malaise, but there is no dyspnea, right? There is no abnormal imaging. Then he is considered to be mild illness. Whereas when do we use the word moderate? We use the word moderate, the individual has dyspnea, but saturation is more than or equal to 94%. Right? Saturation is more than or equal to 94%. And there is also lower respiratory disease as well. Right? There is also lower respiratory disease as well. And how did you tell there is lower respiratory disease? Because there is an abnormal imaging there. Because of abnormal imaging, it has found to be that there is moderate illness. Then coming to, when do we use the word severe illness? We use the word severe illness when the saturation is less than 94%. Right? If it is less than 94%. Or PaO2 by FiO2, right? PaO2 by FiO2 is less than 300 and respiratory rate is more than 30 breaths per minute. So that is called as severe illness. So we use the word severe illness when there is tachypnea, there is hypoxia, and PaO2 by FiO2 is less than 300. That is partial pressure of oxygen by fraction of the inspired oxygen. Then when do we use the word critical illness? We use the word critical illness whenever there is respiratory failure, whenever there is septic shock, whenever there is multi-organ dysfunction. That is the point when we use the word critical illness. That is the point when we use the word critical illness. Okay. So this is about the staging. Asymptomatic, no symptoms. Mild illness, imaging is absolutely normal. Moderate illness, SpO2 more than or equal to 94% and there is abnormal imaging also. Severe illness, SpO2 less than 94%, PaO2 by FiO2 less than 300 and there is tachypnea. Critical illness, they have respiratory failure and as well as the patient is in the septic shock. Now, the point is, some group of individuals who have acquired COVID-19, they are asymptomatic. Some group of individuals who have acquired COVID-19, they are in the stage of critical illness. What is that particular host factor predicting the COVID-19 disease severity? So, if you take the host factors predicting the COVID-19 disease severity, there are two important factors. One is the old age. As the age of the individual increases, there is high chance of the COVID-19 disease severity, right? And if there is lymphopenia is another important factor. Okay, so lymphocytes, whenever they are decreasing, there is high levels of the interleukin 6, high levels of interleukin 18. So these high levels of interleukin 6 and interleukin 18, they are the one which can make the individual to land up in severe or the critical illness. Okay, so this is how you will assess the severity. Now, following that, what are the management perspectives? Right, current non-therapeutic management and supportive care. Therapeutic treatment is different. We have antiviral drugs, right? But non-therapeutic management. See, non-therapeutic management, WHO has classified again. If it is like mild COVID-19, what you will give? Moderate COVID-19, what is that you will do? Severe COVID-19, what is that you will do? What is mild, moderate, severe? Already I have discussed, right? Already I have discussed, okay? Now, you take in case of mild COVID-19, what did the WHO tell for non-therapeutic management? First of all, isolate the patient, right? Why? In order to see that the transmission does not occur. This particular isolation can be at the home and this particular isolation can be in the healthcare facility or in any community, but then it should be complete isolation, either in home or in the hospital, in order to prevent the transmission. Then the WHO said, treat the symptoms. Fever is there, give antipyretics. Then give adequate nutrition, right? And appropriate rehydration. Okay. So symptomatic treatment, that is for mild COVID-19. And you need to educate the patient, right? So educate the signs and symptoms of COVID-19. Educate the patient about the complications of COVID-19. And if he develops any of this complication, immediately he has to take an urgent care. That is according to WHO. That is for mild COVID-19, what are the non-therapeutic management. Whereas, you take in case of moderate COVID-19, what did the WHO tell? For moderate COVID-19, what is moderate? I have already said you in the disease severity. Monitor the patient closely. Why? Because the pulmonary disease can progress rapidly. There can be rapid progression. That is the reason why monitor the patient closely. And you need to administer the antibiotics to the patient if there is any bacterial pneumonia. Okay? And you need to suspect, there should be high level of suspicion for the development of the sepsis. Right? And accordingly, you need to escalate or de-escalate the treatment whatever you are giving. Right? And if there is no infection, you have done chest x-ray, you have done the sampling. If there is no infection, then stop the antibiotic treatment. Right? And in case of moderate COVID-19, please don't stay at the home. Right? So, use hospital infection prevention and control measures. Right? Use hospital infection prevention as well as the control measures. Okay? And in order to prevent that particular aerosol spread, the healthcare individual has to wear the N95 respirators. Okay? So that is about for moderate COVID-19. Like for suppose, if the individual is having severe COVID-19, what are the non-therapeutic management? First and foremost, very important point is patient care areas. Right? For example, the patient is in ICU. In that ICU, equip, that means there should be pulse oximeter, functioning oxygen systems, disposable items, single use oxygen delivering interfaces. These should be there if you are treating a severe pneumonia. Right? And provide immediate supplement oxygen to patients with emergency signs. Right? What are those emergency signs? The individual had developed severe respiratory distress. The individual had developed central cyanosis. The individual has landed up in shock. Individual has developed convulsions. In that case, you need to give immediate supplemental oxygen. Right? And you need to monitor for the clinical deterioration as well. Right? You need to monitor for the clinical deterioration as well and provide immediate supportive care as and when required. Right? As and when required. Okay? And fluid management is also very important. Right? The fluid management is also very important. So, this is the management of severe COVID-19. Right? This is the management of severe COVID-19. And if there is co-infections, definitely you need to give antimicrobial agents. Definitely you need to give antimicrobial agents. Okay? So, this is about like non-therapeutic management. Still we did not add the antiviral drugs. When to add, I will tell you. Right? When to add those, I will tell you. Okay? Now, following that, whenever the individual has gone into a stage of the critical phase, right? Whenever the individual has gone into critical phase, what is the non-therapeutic management you have to add? See, it is not that in case of moderate and as well as severe, you don't add the antiviral drugs. You should add. But first what I am trying to discuss is, I am trying to discuss what is the non-therapeutic management which is required. Oxygen, antibiotic, antipyretics, right? And the antibiotics. What are the actual antivirals? I will come to the discussion. Right? Now, if you take the critical COVID-19 patient, when do we use the word critical? Right? When the individual has landed up in respiratory failure, when the individual has landed up in septic shock, right? And the individual has developed ARDS. That is what is called as the critical COVID-19. So in these patients, you should give high flow nasal oxygen, right? And NIV, non-invasive ventilator for select patients with mild ARDS. And if there is deterioration, in spite of keeping the patient on high flow nasal oxygen, in spite of keeping the patient on non-invasive ventilator, immediately you need to intubate the patient. Right? Immediately you need to intubate the patient. Right? And you need to use low tidal volumes, that is 4 to 8 ml per kg, right? 4 to 8 ml per kg. And you need to apply the prone ventilation. In severe ARDS patients, you need to apply the prone ventilation. And the other important thing is the fluid management is also very important. Conservative fluid management. If no tissue hypoperfusion and fluid responsiveness. Okay. And in case of moderate to severe ARDS, there are studies in between high versus low PEEP suggested with individualized titration and as well as monitoring. And very important thing is you need to avoid neuromuscular blockade by continuous infusion. Don't give that. Okay. And whenever the patient is on mechanical ventilator, avoid disconnecting the ventilator. Right? You should avoid disconnecting the ventilator. And in refractory cases, right, you have put the patient on mechanical ventilator and you are using a tidal volume of 4 to 8 ml per kg body weight, right? And you have applied the prone position, right? Prone position, prone ventilation, okay? And you are also giving adequate fluids and you are monitoring the PEEP depending upon the clinical status of the individual. But still, if the individual is refractory, then you need to consider for extracorporeal membrane oxygenation referral, right? You need to consider for ECMO referral. So that is about the clinical scenario in case of mechanically ventilated patients, right? Next. Now, following that, what are the first line vasopressors that has to be given in case of septic shock in patients with the COVID-19? Because critical phase means what? The individual has landed up in respiratory failure and the individual has also landed up in septic shock. Now, the first line vasopressors in case of the COVID-19 is norepinephrine for adults, epinephrine for children, right? Epinephrine for children. Okay. So that's a very, very important point. Next. Whenever you are giving this particular vasopressors, what should be the mean arterial pressure that has to be maintained? The mean arterial pressure that has to be maintained is more than or equal to 65 millimeters of mercury and lactates should be more than or equal to 2 millimoles per liter without hypovolemia. So this is what is the maintenance of MAP whenever you are giving this particular vasopressors, right? Next. Now, for example, if the individual has developed renal dysfunction, what is that you will do? Right? So when the individual has developed renal dysfunction, renal replacement therapy is indicated. And that renal replacement therapy is in the form of continuous renal replacement therapy, which is nothing but your dialysis. Right? Dialysis. And if CR-RT is unavailable or not possible, prolonged intermittent renal replacement therapy rather than intermittent hemodialysis is recommended. So CR-RT is recommended in case of patients with a renal dysfunction, right? In case of the hematological abnormalities, right? I said you hypercoagulability, right? Very, very bad complication. So you need to give the VTE prophylaxis, that is deep vein thrombosis prophylaxis should be given, that is anticoagulants or antiplatelets should not be used to prevent the arterial thrombosis outside of the usual standard of care. Okay. So this is about the hematological manifestations. If it is like venous thrombosis, right, in order to prevent the development of the venous thrombosis, definitely we use anticoagulants, right? But for arterial thrombosis, anticoagulants or antiplatelet therapy should not be used to prevent arterial thrombosis outside of the usual standard of care. Okay, right. So this is about your non-therapeutic management, right? Non-therapeutic management. Now, at this point, let me tell you, by giving this non-therapeutic management, what all you can avoid, right? What all you can avoid, what all complications that can be prevented, right? What all complications can be prevented. First, mechanical ventilation, that is very important. You have to see that the individual should be out of the requirement of ventilator by giving this your appropriate non-therapeutic management. And you have to prevent the development of VAP, that is ventilator associated pneumonia. the organisms like Pseudomonas klebsiella, they are very common for the development of ventilator-associated pneumonia. You have to prevent the development of VAP, right? And venous thromboembolism, you need to provide or you need to give low molecular weight heparin, right? And if heparin is contraindicated, we give low molecular weight heparin. And we also use the intermittent pneumatic compression devices, right? Intermittent pneumatic compression devices, we give the ventilator, we give intermittent pneumatic compression devices in order to prevent the venous thromboembolism, right? And we need to prevent the catheter related infections, pressure ulcers, stress ulcers. So all these should be avoided, and we have to be of utmost care about the development of the antibiotic resistance. So this is about your non-therapeutic management, right? It is not like your antivirals, it is not like your immunomodulators, okay? Oxygen, ventilator, anticoagulants. This is your non-therapeutic management. Fluids, adequate nutrition, right? Proper posture of the patient, preventing the complications like stress ulcers or pressure ulcers. These are the things like what is very much required in non-therapeutic management. Whereas, if you see the therapeutic management, you have the antivirals, right? And you have the immunomodulators. So if you take the antivirals like what we have is baloxavir, convalescent plasma, favipiravir, hydroxychloroquine, interferons, lopinavir or ritonavir, nitazoxanide, oseltamivir, remdesivir, and then ribavirin. These are the antivirals. These many list of antivirals we have, right? But commonly in use presently is your remdesivir. We will discuss in detail about the remdesivir. Then we have immunomodulators. These immunomodulators, they include the corticosteroids like dexamethasone, interleukin 1 inhibitor, that is anakinra. Then we have interleukin 6 inhibitor, that is tocilizumab, intravenous immunoglobulins, and JAK inhibitors, that is baricitinib. These are the immunomodulators that can be given in the therapeutic management of COVID-19. So now let me take up the discussion on the very important antiviral drug, that is remdesivir. So first of all, you need to understand the mechanism of action of the remdesivir. And this particular remdesivir, it is mainly given for the hospitalized patients and it is FDA approved drug. Mechanism of action is the one where they can ask you the important multiple choice question. So if you take this remdesivir, it is a nucleoside analog of the ATP, right? It is a nucleoside analog of the ATP that inhibits COVID-19 RNA polymerase, right? So what is that it doing? It is a nucleoside analog. It is inhibiting this particular RNA polymerase by competing with ATP, right? So thereby there will be delayed chain termination during viral replication. Okay, so viral RNA replication is being inhibited by this particular remdesivir. Okay, now this particular remdesivir, it is indicated in the adult patients, right? That is very clear approval by the FDA. But in case of the pediatric patients, right, that is in case of children, it is indicated only in the age group more than 12 years and the weight of the individual should be at least 40 kgs. Okay, so this is very important point. Now, if you take the dosage of this particular remdesivir, what should be the loading dose, what should be the maintenance dose, and what is the adult and what is the pediatric dose. So all these are very much important, right? So if you take this particular remdesivir, in case of the adult and as well as the pediatric patients more than or equal to 40 kg, the loading dose, right? The loading dose that you have to give is 200 milligrams on day 1, right? 200 milligrams on day 1. And see, first I am telling you the one where the patient is on mechanical ventilator, right? Where the patient is on mechanical ventilator. Okay, so 200 milligrams on day 1 and followed by that 100 milligrams you should give for 10 days. That will be the maintenance dose. But whereas patients not requiring invasive mechanical ventilation, right? Patients not requiring invasive mechanical ventilation. So in that particular group of patients, you have to give the loading dose same, that is 200 milligrams on day 1, but subsequently you have to give maintenance dose only 100 milligrams on day 2 to day 5, right? On day 2 to day 5. So that is about the dosage of this remdesivir. Loading dose, maintenance dose. And those patients on mechanical ventilator or on ECMO support, you need to give remdesivir for nearly around 10 days. And those patients who are not on the mechanical ventilator or ECMO, you need to give this particular remdesivir only for 5 days. Okay. Now, then followed by that, you need to understand what are the contraindications for this particular remdesivir. Okay. So safety information and as well as warnings are very much followed whenever you are giving this particular remdesivir. Remember, this particular remdesivir, it is contraindicated in patients with hypersensitivity reactions. So in those individuals who has history of clinically significant hypersensitivity reactions, remdesivir is absolutely contraindicated. And that is one. And the other point is, this particular remdesivir, it gets metabolized and it gets excreted through the kidney. So that is the reason why in those individuals where the eGFR is less than 30 ml per minute, right? In those individuals where the eGFR is less than 30 ml per minute, this remdesivir, it is not recommended. That is very important point. Now, the other precautions that you need to take is infusion related reactions, right? So we have come across some of the infusion related reactions whenever this particular remdesivir is being given. So immediately disconnect the remdesivir infusion, right? And you need to take care of that particular significant infusion related reactions, whatever you come across. Next, the other point is the transaminase elevation. See, transaminase elevation have occurred in healthy controls and patients with COVID-19 receiving remdesivir. But when is that you should discontinue remdesivir? You have to discontinue remdesivir if the alanine transaminase levels, if they are increased more than or equal to 10 times. Right? If they are increased more than or equal to 10 times of upper limit of normal. That is the point when this particular remdesivir has to be completely avoided or it should be stopped. Now, you take in case of the special population. Special population in the sense like pregnancy, nursing mothers, pediatric patients, geriatric individuals, renal impairment, right? What is the approach of this remdesivir? So first of all, you take in case of the pregnancy, right? So we don't have any adequate or well-controlled studies giving remdesivir in a pregnant female. And the same story even in case of the nursing mothers also. There is no information regarding the remdesivir in the human milk, right? And what will be the effect on the breastfed infants. So that particular data is not available until now. And you take the pediatric patients, right? So usually what the FDA has approved is, it can be given in those individuals, the children more than 12 years and weight of the individual more than 40 kg. But again, we don't have appropriate data. We don't have the well-controlled studies for the pediatric patients younger than 12 years or weight less than 40 kg. There is no particular data, right? Next, coming to the geriatric patients. See, in geriatric patients, the clinical experience has not identified the differences in responses between elderly and as well as young patients. Okay, so no dosage adjustment should be required whenever you are giving in geriatric patients, that is age more than 65 years. Whatever the 200 milligrams loading dose you are giving, give the same dose. And whatever that 100 milligrams maintenance dose you are giving, you continue the same dose. Okay, but only thing is you need to monitor the hepatic, renal and as well as the cardiac function. So all these three have to be monitored: hepatic, renal, and as well as the cardiac function. Next, coming to the renal impairment. So regarding the renal impairment, I have explained just before only that in patients with eGFR less than 30 ml per minute, please don't give remdesivir. Remdesivir is not recommended, right? Then same story is related to your hepatic impairment also. That is, when the alanine aminotransferase levels, when they are increased more than 10 times the upper limit of normal, then please stop giving this remdesivir, right? Please stop giving this remdesivir. Okay, so that is about the FDA approval for the remdesivir. Right, now you take in case of pediatric patients, right? As such, we don't have the data for giving remdesivir in pediatric patients, but what is the recommendations, right? What is the recommendations in pediatric patients? The recommendations in pediatric patients is that when the age of the patient is less than 12 years of age, the loading dose what you need to give is 5 milligrams per kg, and maintenance dose what you need to give is 2.5 milligrams per kg, right? Loading dose is 5 milligram per kg and maintenance dose is 2.5 milligrams per kg. Okay, that is if the weight of the individual is in between 3.5 kg to less than 40 kg. More than or equal to 40 kg, already I have discussed, 200 milligrams loading dose, 100 milligrams maintenance dose. So that is about the data on the remdesivir. Now, followed by that, the very important group of drugs that is very much required in these patients with the COVID-19 in critically ill patients is the dexamethasone, that is corticosteroids. So, if you take this particular corticosteroids, which particular corticosteroid is advised is dexamethasone. This particular dexamethasone, it is a corticosteroid with anti-inflammatory effects, right? It has the anti-inflammatory effects. Okay, and that is used or that has been used to treat, see, corticosteroids are not just having the anti-inflammatory effect use in your COVID-19. It can also be used in the treatment of asthma, dermatitis, rheumatic disorders, mitral stenosis or other autoimmune disorders also. These particular corticosteroids are given. And this dexamethasone, if you see, it can be given intravenously or orally. But what is the contraindication of dexamethasone? Remember, this corticosteroid group of drugs are those which will reduce the immunity of the individual. And they are more prone for the fungal infections, those individuals who are on long-term steroid therapy. So that is the reason why, remember, if the patient is having any systemic fungal infections, right, if the patient is having any systemic fungal infections, the dexamethasone is contraindicated. Right, dexamethasone is contraindicated. Whereas in pregnancy, the dexamethasone is considered as the category C. Right, dexamethasone is considered as the category C. Okay, so that is about the role of the dexamethasone. Now we will see like what will be the treatment guidelines related to your corticosteroids for COVID-19. So what is the guidelines of the WHO, like when we should give the corticosteroids? First and foremost, the critical COVID-19 patients. So now what do you understand by the word the critical COVID-19? The patient with ARDS, the patient in sepsis with COVID-19, the patient with in septic shock. So these are considered as the critical COVID-19 patients. And these patients are on mechanical ventilator support and these patients are on vasopressor therapy. And what is the recommendation related to your corticosteroids? These patients have been recommended with systemic corticosteroids, right? Systemic corticosteroids, that is intravenous dexamethasone is being recommended. Whereas you take severe COVID-19. What do you mean by severe COVID-19? Severe COVID-19 is that oxygen saturation is less than 90% on room air. Tachypnea is that respiratory rate more than 30 per minute. And the other important thing is the individual is having the signs of respiratory distress. He is using the accessory muscles of respiration, right? Inability to complete full sentences. That is what is nothing but the signs of the respiratory distress. Okay, so in these patients, you need to recommend the systemic steroids, right? Systemic steroids. Whereas in case of non-severe COVID-19, where there is absence of any signs of severe or critical COVID-19, corticosteroids are not recommended, right? Corticosteroids are not recommended. So in critical COVID-19 and in severe COVID-19, systemic corticosteroids are being recommended by the WHO. Then followed by that, the next important thing is the coagulopathy in COVID-19. See, we are very much worried about the coagulopathy in the COVID-19, right? Why the coagulopathy will occur in COVID-19? Let me explain. As a part of this coagulopathy, the individual can develop deep vein thrombosis. The individual can have the coronary artery disease. The individual can have the cerebrovascular accidents. And the individual can also have the APLA syndrome. So these are all the things like what we have seen related to coagulopathy. And this particular coagulopathy, right, it is due to what is called as thromboinflammation, right? So there is thrombus formation and there is also the inflammation of the vessel, finally leading to the coagulation, right? Finally leading to the coagulation. Now, what exactly is the pathophysiology for the development of the coagulopathy? Let me explain. So we have an entity called endothelitis, right? We have an entity called endothelitis. So it is the endothelitis, that means the inflammation of the endothelial vessels, that has been postulated as the central feature of the pathophysiology in these particular patients with the COVID-19 causing the coagulopathy. Okay, so endothelitis, that has been postulated. Okay, so the cause for this particular coagulopathy is your endothelitis. See, what happens is this COVID-19, it binds to the host cell, right, via receptor. And what is that particular receptor? That is your ACE2 receptor. Now, why is it causing this particular endothelitis? Why? Because the ACE2 receptors on which the COVID-19 binds, they are like highly, densely distributed on the endothelial cells. Okay, so there is high density of ACE2 receptors on endothelial cells, right? High density of the ACE2 receptors that are being distributed on the endothelial cells. Okay, that is very, very important. That is the reason why the individual is having the endothelitis. So more and more COVID-19 is going and binding to this particular endothelial cells, causing the inflammation of the endothelial cells, causing endothelitis. Okay, so endothelitis and as well as the viral inclusions in the endothelial cells have been reported in COVID-19 autopsy series. Now, when there is endothelitis, why there will be the clot formation? Why there will be coagulopathy? Right? Everyone should be aware of what is called 𝘂𝐻 right? Everyone should be aware of 𝘂𝐻 for the development of the hypercoagulability or the clot formation. What is 𝘂𝐻? That includes the following. Number one, endothelial dysfunction, right? Number one, endothelial dysfunction. Number two, there will be alteration in the flow of the blood, right? 𝘂𝐻 in COVID-19 is different from the 𝘂𝐻 like what we have for the clot formation. Endothelial dysfunction, hypercoagulability, then stasis of the blood. These three factors will predispose to the formation of the clot. In COVID-19, one, your organism is coming and binding to your ACE2 receptors which are present on the endothelial cells. That is causing vascular endothelitis. And once there is vascular endothelitis, the subendothelial collagen is being exposed to the flow of the blood. So the platelets, they are getting activated, right? There is platelet activation and there will be also alteration of the blood flow. So these are the three components which constitutes the 𝘂𝐻 in COVID-19 causing the development of the clot. Okay, so there has been different approaches for the thromboprophylaxis. So COVID-19, don't be under the impression that it is just only pulmonary manifestations. Apart from pulmonary manifestations, you have extra-pulmonary manifestations, right? And you also have the development of the clot, right? You also have the development of the clot. Now, let me explain you what are the thromboprophylaxis, like what we need to take against this particular COVID-19. So the point is that in case of the clinical scenario where the D-dimer is less than 500 nanogram per ml, in such case, you need to give low molecular weight heparin. Subcutaneously, it is being preferred. That is the prophylactic anticoagulation when the D-dimer value is less than 500. But whereas you take therapeutic in the sense D-dimer value is elevated. D-dimer value, if it is like in a range of 2000 to 10,000 nanogram per ml, that is the point when you need to consider the therapeutic dose of the low molecular weight heparin, right? So you need to consider the therapeutic dose of the anticoagulation. The word AC stands for anticoagulation. Okay, next, followed by that, you take the second scenario. In a second scenario, in all patients, unless absolute contraindication, that means in the second institutional approach, what they have given is give anticoagulation to all the patients until unless contraindication, right? Until unless contraindication. COVID-19, give low molecular weight heparin. This was the other institutional approach, right? And the third one is no known thrombosis and D-dimer value less than 3000 nanogram per ml. That is the point when they have started giving this particular anticoagulation. So there are different institutional approaches for giving this particular anticoagulation. But what is being followed is this. Okay. D-dimer value less than 500, give prophylactic anticoagulation. D-dimer value in a range of 2000 to 10,000 nanogram per ml, then therapeutic anticoagulation should be given. Right? Therapeutic anticoagulation should be given. Now, summarizing this everything, let me tell you what are all the treatment approaches by the National Institute of Health guidelines. So, at what level this particular various drugs have to be introduced, right? Let me show you that, right? So, if you see the COVID-19 related therapies, in early stage, where there is viral response phase and the individual is having lymphopenia as well, right? In this clinical scenario, you need to give non-therapeutic strategies like antipyretics and as well as antibiotics. That is in early infection. But when the individual is developing the pulmonary phase, that is stage 2. Right, stage 2 again, we divide that into 2A and as well as 2B. So pulmonary phase means the individual is developing shortness of breath and as well as there is also abnormal chest imaging. So whenever the pulmonary phase has set in, immediately you have to start this remdesivir. Dosages and all already have explained. Whereas in stage 2B, right, in stage 2B, that is the point when we need to add this particular dexamethasone. Right, that is the point when we need to add dexamethasone. Okay, and in case of the hyperinflammatory phase, that is individual has developed ARDS, individual is in shock, the individual is in a state of cardiac failure. In such case, you need to give dexamethasone in full dose and the patient has to be put on the high flow nasal oxygen or the patient has to be completely intubated. Okay, so these are like different stages. Stage 1, early infection. Stage 2, pulmonary phase. And stage 3, the hyperinflammatory phase. Now, we have NIH guidelines for the therapeutic management. That is when to start dexamethasone and when to start remdesivir by the NIH guidelines. Like the individual is not hospitalized, or that means you take this first scenario. Right, the individual is not hospitalized or hospitalized but does not require the supplemental oxygen, right? But does not require the supplemental oxygen. In this clinical scenario, please remember, don't start dexamethasone, right? Don't start dexamethasone. And there is also insufficient data to recommend for the remdesivir also in non-hospitalized patients or hospitalized patients but does not requiring supplemental oxygen. Whereas you take the second scenario. Second scenario is like the individual is hospitalized and he is requiring supplemental oxygen. For them, undoubtedly you start remdesivir. That means the pulmonary phase has set in. You have to give remdesivir. 200 milligrams on day 1, followed by that 100 milligrams intravenously for 4 to 5 days until the time of discharge. Okay. And for example, if the individual is requiring the oxygen support with high flow nasal oxygen, right? High flow nasal oxygen, you take the third scenario. So here only oxygen is required, not high flow nasal oxygen in the second scenario. Whereas in the third scenario, the individual is hospitalized and requiring high flow nasal oxygen or non-invasive ventilator. In these patients, along with remdesivir, you need to start this particular dexamethasone. And this dexamethasone, 6 milligrams IV should be started up to 10 days or until the time of discharge. Whereas you take the last scenario. The last scenario is that where the individual is hospitalized and the individual has set up a very severe ARDS and the patient is on mechanical ventilator and or the patient is on the ECMO support, then in such case you need to continue the same, that is remdesivir or dexamethasone, but here you need to give this particular dexamethasone for nearly around 10 days. Okay, so the treatment strategy for the patient on high flow nasal oxygen and as well as the patient on mechanical ventilator, right, it is more or less same. Right, it is more or less same. Now, what are the new drugs? Right, so what are the new drugs which are in the pipeline? This is the other question that can be asked in your exams. So, if you take the new drugs, see, this is the data which I am giving to you until December 18th, 2020. By the time you people write the exam, there may be addition of lot more data because this COVID-19 is a pandemic which is going all over the world. So there are lot many new drugs, right? Lot many new vaccines will be added to your pipeline. So you should be completely aware and you should be completely updated related to the data on COVID-19 before you going to the exams. Now we have a monoclonal antibody, that is bamlanivimab, right? So this bamlanivimab, the treatment is mainly to control the viral load, to reduce the hospitalization. So this is the trial which is going on this particular drug, that is bamlanivimab, to reduce the viral load and as well as the hospitalization within the individual, right? But because of the emergency, what the FDA has done is, FDA emergency use authorization of bamlanivimab to treat COVID-19 has been released into the market. Okay, that means without any particular proper studies, the FDA has permitted this particular drug on an emergency basis. Okay, so it is an unapproved product for the treatment of mild to moderate COVID-19 infections. Why this particular drug has been introduced? Why on an emergency basis that has been introduced into the market by the FDA? Because remdesivir we were unable to give in children less than 12 years. Children less than 40 years, we were unable to give this particular remdesivir. So as an emergency basis, this particular monoclonal antibody has been introduced into the market, that is bamlanivimab. And the dosage of this particular drug is intravenous infusion 700 milligrams, that has to be given at least 60 minutes, right? At least 60 minutes. Okay. So this is about one of the new drug in the pipeline for the COVID-19 infections. And which patients have to receive this particular drug? Which patient has to receive this drug is patient with at least one of the following. See, this drug has been introduced mainly to substitute remdesivir where we were unable to give remdesivir. Remdesivir we were not giving in a CKD patient where the eGFR is less than 30. So in that case, give your 𝘂𝐕𝐈𝐃. Okay, so CKD patients or diabetes, BMI more than or equal to 35, immunosuppressive disease, right? Currently receiving immunosuppressive treatment, age more than or equal to 65 years of age. So in these particular clinical scenarios, you can give this particular the 𝘂𝐕𝐈𝐃. Now, the recent trend which is going on the COVID-19 is the vaccines. So on vaccines, definitely you will have the questions. You will have the questions. Okay. So before going on to the vaccines, let me tell you some of the updated immunomodulatory therapies. So we have, what is the basic pathogenesis? In the pathogenesis, I have said you, cytokine storm, that is interleukin 6 is released into the circulation, interleukin 10 is released into the circulation, and that is the one which is causing inflammation in various organs. So interleukin 6, it will go and bind to a receptor, so give an anti-interleukin 6 receptors, right? You give an anti-interleukin 6 receptors, and that particular drug which is in the pipeline for the study is tocilizumab, right? So this is the study from Italy. Tocilizumab, it is your anti-interleukin 6. Then we have the other group of drugs, that is JAK1 or 2 inhibitors. Because these particular JAK1 or 2 inhibitors, why we should give? You take these cytokines, whichever have been released, they are coming and binding to this JAK1 and as well as JAK2. And that is making the individual to land up in the hyperinflammatory state. So, in order to nullify this particular JAK1 or JAK2, we have a drug that is baricitinib, right? So, this is also a trial which is going on. Baricitinib, which is acting on JAK1 and as well as JAK2. Okay, right. So, this is the data on the new drugs which are in the pipeline. And some more new drugs include ruxolitinib. This is another drug which is in the pipeline. Okay. Now, after having discussed about the immunomodulators, let me tell you about what is the status of the vaccine development. As of now, remember, there are totally 86 plus vaccines in the preclinical phase. That means preclinical means vaccines not yet in the human trials. 41 vaccines have entered into phase 1. So this is a data up to December 18, 2020. Phase 2 trials, almost 16 vaccines have entered into phase 2 trials. And the other 16 vaccines also have entered into phase 3 trials. And the vaccines which has been approved by the FDA, we have only 2 vaccines. Right, we have only 2 vaccines. Now, what are those 2 vaccines? Those 2 vaccines include the vaccine prepared by Pfizer, right? Vaccine prepared by Pfizer, and as well as the Moderna. And the vaccine prepared by Pfizer, it is BNT162b2. And the vaccine prepared by Moderna, it is mRNA 1273. Okay, so these are mRNA vaccines against the SARS-CoV-2. Okay, right. Now, what is the schedule? either you take Pfizer vaccine or you take Moderna vaccine. You have to give 2 doses. You take the vaccine by Pfizer. The vaccination has to be done on day 1 and as well as day 21. Right, day 1 and as well as the day 21. But age group is again precise, in persons more than or equal to 12 years. In persons more than or equal to 12 years of age. So the 2 doses has to be given. Now, what is the end point of this particular Pfizer vaccine? What is the efficacy? The efficacy is 95% on 7th day. That is the maximum efficacy of the Pfizer vaccine. Whereas the Moderna vaccine, if you see, the efficacy, it is around 94.5% 14 days after the second dose. See, the efficacy will begin only after the second dose. So, Pfizer vaccine you are giving on day 1 and day 21, whereas Moderna vaccine you are giving on day 1 and as well as day 20. Pfizer vaccine was approved for age more than or equal to 12 years. Whereas the Moderna vaccine, it has been approved for age group more than or equal to 18 years. Okay, so this is the data on the vaccine. So the FDA approved vaccines, like we have only 2 vaccines as of now, FDA approved. One is Pfizer vaccine and the other one is the Moderna vaccine. Now, if you see the evaluation of the vaccine candidates, right? Evaluation of the vaccine candidates. How long will the protection last? Right? How long the protection will last is that, see, this is the Pfizer vaccine and this is the Moderna vaccine. This is made from 7 days and as well as 14 days post second vaccination respectively. Right? And what is the long-term safety? Still the studies are going on. And for how long the protection will last? Still the studies are going on. Because the vaccines have been recently introduced. What will be their efficacy? How long the protection will last? What is their long-term safety? All that we have to wait and see. Right? Storage. You take the Moderna vaccine, that is mRNA 1273. It is stable at refrigerated temperatures for 30 days, or even it is stable at room temperature for 12 hours. Okay. Whereas you take the Pfizer vaccine, that is BNT162b2, it is stable at temperatures more than or equal to minus 70 degrees, but it is not yet demonstrated. Not yet demonstrated. Okay. So this is about the vaccines. And the dosing, if you see, like Pfizer vaccine, right? If you take the dosing of the Pfizer vaccine, I said you 2 doses, right? And these particular 2 doses should be given on day 1 and as well as day 21. But how much is that particular dose? The dose is of 0.3 ml each, intramuscular, 3 weeks apart. Right? Intramuscular and 3 weeks apart. So this is about the Pfizer vaccine. Now, what is the data in pregnancy about the vaccination? That is the use of vaccination in the specific population. Pregnancy, still the data is not available. Lactation, still the data is not available. Pediatric patients, still the data is not available. Okay. So, in special populations, the data of this particular vaccine is not still available. So, this is the updates related to your COVID-19 as of December 18, 2020. Right? By the time you go to your exams, you should be having a complete update on this particular topic of COVID-19. Thank you very much.